We go beyond the journal articles and into the laboratory and the field as scientists share their discoveries in a way everyone can understand. It's science explained. You're listening to Science Sound Off on Texas A&M Health Talk. Welcome to Science Sound Off. I'm Christina Sumners.
And I'm her co-host, Tim Schnettler.
And we're here today with Dr. Jane Bolin. Welcome to the podcast.
Thank you.
Could you tell our listeners just a little bit about yourself?
Well, sure. Currently, I have dual roles. I'm the Texas A&M Associate Dean for Research at the College of Nursing, and I'm also a tenured full professor at the Texas A&M School of Public Health.
Wonderful. Well, we're here today with you to talk about colon cancer screenings and prevention. And I know you've done a lot of work in that area, especially in the Brazos Valley.
We have. We are currently serving 17 counties in this greater Brazos Valley region, and we have been working in cancer prevention generally and colon cancer specifically since 2011, which was our first major funding opportunity through the Cancer Prevention Research Institute of Texas, along with the College of Medicine and College of Nursing.
Wonderful. So tell us a little bit about that first grant. What were you doing with it? What was it all about?
Sure. It was a joint effort because of the shared passion for cancer screenings between myself and my team at the Southwest Rural Health Research Center and Dr. David McClellan, who was at that time the director of the Family Medicine Residency with the Texas A&M College of Medicine. Both of us had parents. Our mothers had passed away due to colon cancer, and so it was a topic that was near and dear to our hearts. And when the Cancer Prevention and Research Institute of Texas announced funding for programs that would not only prevent but educate and screen, we shared our dual sort of vision for what we could put together to institute a program for colon cancer prevention and screening in the greater Brazos Valley.
Wonderful. And let's take a step back for just a second. What is colon cancer, colorectal cancer? Are they the same thing?
Yes, generally. Okay. So colon cancer would be abnormal cancerous lesions that are actually up in the colon. Colorectal cancer would also involve the end of the colon or the rectal area, which is actually quite common. You'd be surprised how common it is. And so the term is colorectal cancer screenings, and that it's generally there are a number of degrees of findings that one might see when they're doing screenings, but certainly with appropriate screening, you can visualize cancers in the colon.
And so is that why screening is so important? Is because you can see these cancers?
Yes, they're very slow growing. They generally start with precursors to cancers like polyps or diverticuli, which are reverse pouches in the colon that tend to gather and accumulate waste matter, and certainly that's what the colon is for. It's the waste viaduct for our digestive system, and so polyps hang down, and diverticuli are recesses, and any kind of abnormal finding like that would be noticed by a physician, and those areas can be removed through either surgical, but with a colonoscopy, polyps can be just excised pretty easily. But with a colonoscopy, the physician can also see abnormal like inflammation, Crohn's disease, and those are also known to be precursors to cancer. And so treatment would be important to reduce inflammation and keep a watchful eye on the area for the person that may be experiencing that.
So we always hear early detection or early findings is the key to all of this. And the way you're talking, this is something that really early detection is a huge part of.
It is. You're exactly right. So for the person who hasn't had what we refer to as a first-degree relative who has had cancer, the normal screening period would start around age 50 for your first colonoscopy, but then it's good for 10 years, or generally recognized because of the slow-growing nature of colorectal cancer. And so if a person has a colonoscopy, it's generally agreed that that's good for 10 years. Then you have your second one at 60, and then you're good from there on out if there are no abnormal findings. If there are polyps found, then it's recommended that they be excised or removed, and that it be repeated within 2 to 3 years, depending on the size of the polyp. So being able to visualize it, because it's so slow growing, and remove the abnormal lesion, it is far better for the person than actually having colon cancer, because it's so painful.
You mentioned, I can't remember the term you used, first
degree relative.
First degree relative. Is that like mother, father, uncle, aunt? What technically is a first degree relative?
Those that you mentioned, mother, father, brother, sister, aunt or uncle would be considered a first-degree relative, and the recommendations are that if colon cancer has been diagnosed in a first-degree relative, that then the family members start their screenings 10 years earlier than the age of diagnosis of the person who had it first.
So you mentioned a few of these risk factors for colon cancer. Mm-hmm. So that would be Crohn's disease, other inflammation.
Right, polyps. Crohn's disease, inflammatory bowel syndrome, a first-degree relative having had it, but it's also associated with obesity generally. It's also associated with a diet that's high in processed foods, and also associated with high consumption of alcohol, among other things. There are a number of factors, but I think the most serious are the first degree and then having active symptoms yourself.
And what are those symptoms?
Well, would be symptoms of irritable bowel, which would be the cramping in the lower intestine. Certainly, anyone who notices blood in their stool should immediately be screened and have a full colonoscopy. And the good part about a colonoscopy now, it's not just limited to the lower descending bowel, but it actually, the scopes now are smaller, flexible, and they can reach all the way up to where the large colon and small colon join at the cecum, or what we refer to as the appendix. And so part of screening is to get that scope all the way up to the very end of the large bowel or the colon, so that the scope is seeing it, and then to slowly withdraw through the entire colon, visualizing throughout the diameter of the colon as one withdraws it very, very slowly and looks at it all the way out. And then if there are any abnormalities found, to just actually excise them right there through a wire. I won't go into it, but it's actually very easy. And then those tissue samples are removed and then examined by pathologists.
So let's talk a little bit more about the process. You mentioned once you actually get in there for the colonoscopy, I know people are often scared about what the prep is like.
Right. That's probably the very worst thing about colon cancer screening if you're going to have a colonoscopy, because it's 2 days of prep that's not very pleasant, because one is generally fasting and not eating solid foods or anything that other than clear liquids. And so it's not very much fun. It's a bit of a process to go through until the scope is over. So it's basically cleansing the bowel. And so what we do over at the clinic, and we try to make it culturally appropriate. We have bilingual promotoras or CHWs that are there assisting the staff and the physicians and the nurses, and they give them their medication, or it's not really medication, but it's just something that will quickly cleanse the bowel. And so everything, there's no residual left behind, and the person conducting the colonoscopy can really see the bowel very clearly.
As someone who is approaching the age of 50, knowing that this is on the horizon for me, I mean, what you just talked about, ease my fears a little bit more. I mean, there's always been that, oh my gosh, a colonoscopy. And I'm sure a lot of people out there have that same reaction to it, but it's something that's so important. And really, it's not that difficult a procedure, is it, other than what you just talked about?
Yes, you're exactly right. Aside from and they've narrowed that window down for cleansing now to 1 day, really. You stop eating the day before, and then the 1 day of clear liquids is really just 1 day, and then you go in early the next morning for the procedure. So it's just that, and by having the colonoscopy with the scope, you can then, assuming everything's clear, then sort of be assured that I'm good for another 10 years.
Right.
Whereas if you have the FIT tests or the stool sample tests that detect blood or the other DNA that might be associated with cancer, that's a year-to-year thing. So you're going through it every year. And then if there's any abnormality, you're going to undergo a colonoscopy anyway.
Right.
So there are many things that can make a false positive, such as having had steak the night before or red meat, and then you have that false positive and you're going to undergo a colonoscopy anyway. So because insurance covers it, it's just that 1 day of undergoing the prep, and it's a bit of a discipline, but then you feel, at least I did, I feel good afterwards because it kind of cleansed my system.
Exactly. It's 1 day for a prevention for a life, almost for a lifetime, or for the rest of your life.
Exactly. Yeah. So it's worth it, in my opinion. It's 10 years of, nobody saw anything. That's great.
And just for the procedure itself, how do you all train the family medicine residents in how to do the procedure?
So actually the training occurs over at the Family Medicine Residency Clinic. They have some champions there who are actually certified by the American Society of Gastroendoscopists. They've undergone the requisite number of colonoscopies. We, through the generosity of the grant itself from CPRIT, were able to purchase a simulator, a computer simulator that comes programmed with various kinds of things that abnormal things that may be seen when one performs a colonoscopy. So the residents go through all those modules, if you will, and it has a scope that they're manipulating up through its hand-eye coordination, and they're manipulating the scope up through this simulated colon. It's interesting, if they bump into the side of the colon, the simulator groans like a patient would, and they know that they need to back off and come at it another way because it's not easy getting around the curves and corners. So they undergo that initial training, then they go in and watch with the senior residents and the physician in charge. And then finally, as they advance through their 3 years of family medicine residency, they themselves will be performing the colonoscopy, and hopefully they will. And the plan is that, and it has worked, in fact, that they all have the requisite number of trained and observed colonoscopes, or actually having performed those themselves, that when they get out and they go to small rural hospitals or go into a town, that they will have the necessary skills that their hospital or a clinic will certify them to conduct those exams. Because not everyone can go into a big city to have a GI specialist perform it for them. And we find that rates are higher in rural areas. We found that the stage of diagnosis of colon cancer is far worse in rural areas. So that makes mortality rates higher for colon cancer. And it is the second highest cause of death in the United States related to cancer.
Even though it's so preventable with the proper screening.
Right. It is one that grows very, very slowly, but most people don't experience symptoms often until it's too late.
You mentioned that insurance does cover colonoscopies, but what about for people who don't have insurance or don't have good insurance?
Great question. The CPRIT funding for the Family Medicine Residency and the Health Science Center and the School of Public Health and the College of Nursing has actually provided free colon cancer screenings now for close to 2,500 patients in the greater Brazos Valley who don't have insurance or are underinsured. So they oftentimes may only get 50% of it paid for by their insurance company. And to go to a GI specialist, it may be in the several thousands of dollars to undergo this procedure. So this grant actually pays for the clinic, the time and the scopes, the prep, and the percent of the staff time needed to instruct the patient. All that takes money. And we have performed now close to 2,500 free colonoscopies with the CPRIT funding. So it's a great situation, win-win for the Health Science Center and the residents of the Greater Brazos Valley.
So of those people that have been screened, what percentage actually had some sort of precursor or actual cancer?
35% of the colonoscopies that have been performed have shown abnormal pathology, and 25% of those had revealed cancer precursors,
Wow.
which would be the polyps or the abnormal tissue. Of those, approximately 20 have been actually diagnosed with colorectal cancer and have gone in for treatment. We, through the use of community health worker promotores, have gotten the word out either through Radio Allegra and other mediums such as back-to-school events or health fairs, different avenues of educating the public. We have close to 200,000 individuals that we've reached through this cancer training program. Over 12,000 have been reached face-to-face, and 41,491 professionals have been reached about this through our letters. And I'm sure you want to know about the results, right?
Yes.
Of course, and we have to track that, and we're very proud of the outcomes. So, of the total number of colonoscopies, we track carefully to ensure that we're meeting the American Society of Gastroendoscopists guidelines. And we have, in 96% of our cases, we have attained the cecum, which is a benchmark for a total colonoscopy screen. So the cecum, remember, is where the large bowel and small bowel meet, and that's the very end of the colon. Now, the standards or benchmarks require a 95% rate, so we've exceeded that. We've met that. Overall adenoma or cancer detection rate is expected to be at 20%.
Okay.
We've met that at 27% of the time. I mean, we've detected 27% adenomas. In females, it's as high as 26%. Even higher in males. We're seeing higher cancer rates in males, which is not unusual because of the reluctance to go in for screenings generally anyway. Spend time in terms of healthcare. We also look at the total withdrawal time of the scope back out the colon to assure that it's being visualized as carefully as possible. The physicians at the family medicine residency took a total of 18 minutes per patient to visualize the colon as it's slowly withdrawn. And then that's part of their teaching function because they're all looking at it and observing things. The total mean withdrawal time recommended is just 6 minutes.
Oh, wow. So we're spending 3 times
Yes,
as long? Okay.
3 times as long to observe the colon. So we're very proud of the outcomes that this program has demonstrated. The physicians who are in charge of this program all have excellent records in terms of the sheer numbers and volume that they're doing. So it has been an excellent program for the family medicine residency in terms of having that extra special something to train family medicine residents, including the public health, nursing. Now, nursing, the College of Nursing is also much more involved in the breast and cervical cancer screening, and we do make available FIT testing. But recognizing that the colonoscopy is something that has to be done in a clinical setting, that the family medicine residency certainly has an excellent record in that.
And the School of Public Health is involved through getting the word out about these screenings?
Getting the word out, engaging school public health students in their practicum. They're out providing presentations, health fairs, going to back-to-school events, and just in general educating the lay public about the importance of this.
And if someone in the Brazos Valley is interested in the program and maybe doesn't have insurance but knows they need a colonoscopy, what's the best way for them to get in contact?
Our website, the C-STEP website, we'll put it up on the podcast, has a contact person, as well as the family medicine residency on 29th and Briarcrest. So we'll make that information available, the phone numbers to call, and who to engage with. And we do have bilingual CHWs or community health workers who can instruct the patient, and we do also engage with patients to arrange rides and transportation. So, it should be a much easier process for people to get this important screening.
If, say, there's a listener outside the Brazos Valley listening to this, are there programs similar to this outside of the Brazos Valley where someone can go?
There are, yes. We recently expanded our residency training program to Cuero, adjacent to Victoria. Mm-hmm. They're in the Detar, Cuero counties, and so A&M has expanded it. We do referrals. So if someone says, I've noticed bleeding, and I would really like to be screened, but I'm uninsured, we have gone ahead and contacted the folks at CPRIT and received permission to go ahead and conduct the colonoscopy, even though they're not really in our 18-county service area. Right. So, yes, we have sought permission to go ahead and do that if someone has outright symptoms. And
you mentioned that y'all have expanded it to Cuero and some others. Is there plans to try and expand it even further? Are there other areas where y'all are looking to get into?
Yes. We have currently plans to expand actually down to the lower Rio Grande Valley, to the McAllen area, and to literally make it available all the way up into the areas served by Healthy South Texas.
Well, and you mentioned that there's some other screening tests, but maybe they're not as good, not as effective. What are these other options, and why do you recommend a colonoscopy rather than some of these other tests?
Other tests are tests that take a sample of the stool and put it on a reactive, on a test strip, and then it's tested for either DNA markers or blood or immuno signs of the fact that cancer is present. So take the FIT test. Well, FIT stands for fecal immuno test strip, and it detects immuno DNA-related residual in the stool that has been identified as being associated with colorectal cancer. But it also, these same tests will also pick up blood that may be a false positive. So if someone has eaten red meat, that will be a false positive, or may pick up something else that may have been associated with, let's say, consuming aspirin, for example, has been known to cause the bowel to have some bleeding in some individuals. And so that also could be a false positive, and any kind of false positive leads to a colonoscopy anyway. And so it makes sense in terms of time and cost to just go ahead and have that colonoscopy once every 10 years.
And I've heard about a virtual colonoscopy. What is that, and is that as good as a regular colonoscopy?
A virtual colonoscopy would be the ingestion of a small device that would be passed through with a bowel movement, but as it descends through the colon, it allows the person who is observing the data generated by this device to observe the colon, the inside of the colon, as it's passing through.
For a virtual colonoscopy, you still have to do the prep part of it?
Yes.
So it doesn't really save you much in terms of the experience for the patient?
Probably not. I've never had one.
Got it. That makes sense. Well, we're just about out of time, but Dr. Bolin, is there anything else you'd like to let people know?
Again, this is an important screening. It's something that is truly life-saving, and colon cancer screening does save lives. I can't emphasize that strongly enough. It is not a pleasant thing to have colon cancer, and it is a painful death, and it's tragic that more people don't undergo this simple procedure, relatively simple procedure, once every 10 years for 2 times in their life to avoid the pain associated with colorectal cancer. So I strongly urge all of our listeners to make that appointment and get the screening done.
And I think that's a really great message to end on. Thank you so much, Dr. Bolin, for being with us today.
Thank you for having me. I appreciate it.
And thank you all for listening. This has been another episode of Science Sound Off, and we will see you next time.
Thank you for joining us on Texas A&M Health Talk, a production of the Texas A&M University Health Science Center. Visit us on the web at vitalrecord.tamhsc.edu, where you'll find answers to all of your health questions. Until next time, stay healthy.